We have now already two big trials which have been published during the last 2 years. The empiric outcome trial with empagliflozin and the CANVAS program with canagliflozin. And both trials show a significant reduction in major cardiovascular events and also a major reduction in the hospitalization for heart failure. Also in the empiric outcome study, there was a reduction in cardiovascular mortality and all-cause mortality. Both clinical trials, empiric outcome and CANVAS, were in randomized controlled trials in very selected population, the population mainly with secondary prevention of cardiovascular disease. All these patients have already had cardiovascular events. So I think that to move to clinical practice, it is important to see what happens in real life. And I think the CVD-REAL will be an important information because all this population will be followed in routine clinical practice and provide very valuable information about the possibility to protect type 2 diabetic patients against cardiovascular disease in real life. So empiric outcome was with empagliflozin, CANVAS program was with canagliflozin. We have no information until now with dapagliflozin, for instance, in the DECLARE trial is ongoing and we will have the results in 2 years. So another point also which is important that in the empiric outcome and also in CANVAS program, most of the patients were in secondary prevention. And secondary prevention is only 20% of the population with type 2 diabetes has secondary prevention. So it is important to know what is occur in primary prevention. And the CVD-REAL study provides some information with dapagliflozin first and also in a large population in primary prevention. So the results of the CVD-REAL study were confirming almost the results of the CV outcomes trial because in this population, in real life, the results show also a significant reduction in all-cause mortality and also a significant reduction in hospitalization for heart failure in patients receiving SGLT2 inhibitors compared to patients not receiving SGLT2 inhibitors. And I think also this large survey was performed in the United States, mainly patients treated with canagliflozin, and also in 5 or 6 countries in Europe, mainly in patients mainly treated with dapagliflozin. So these results confirm also that the results in the States with canagliflozin and in the Europe with dapagliflozin are almost the same, suggesting that it is a class effect, protective class effect of SGLT2 inhibitors. So I think that today we use a stepwise approach to manage type 2 diabetes. We start with metformin and with another compound and third compound. I think that first early combination therapy will come earlier in the management of type 2 diabetes. And also I think that metformin could be also challenged because we have very poor information, poor evidence that metformin is able to reduce markedly cardiovascular mortality because we have only a subgroup of the population in the UK PDS. Now we have 2 big trials showing the SGLT2 inhibitors are able to reduce major cardiovascular events. And I think in this population with antecedent of cardiovascular disease, I think that maybe SGLT2 inhibitors may come in front of the treatment for this population.